It's so great to be back on Stanford's campus with old friends and new friends here on campus, as well as to see the changes that have come to this campus. You know, to be back and see that Lane Library has not changed from the time that my wife and I were medical students here, but also to see that buildings like this that was a parking lot during the time that I was at medical school have been erected. It's also great to be back on campus where both of my daughters are undergraduates in the audience, Kelly and Victoria, and my rooting section D. And my wife, Nicole, who's back probably at Stanford since the last time we were here as medical students. So these are my disclosures. They relate to my work in the lymphomas, where I've served as a consultant to the development of new therapies. Most specifically related to this talk is my work with Foresight Diagnostics. It's been the developer of a cell-free DNA technology. I won't talk about that specific technology, but about cell-free DNA in general, and research funding related to my role as the division head for cancer medicine, where I oversee all the strategic industry ventures and alliances between MD Anderson and companies. And the only one relevant there is my work with Genentech that relates to the development of therapies for diffuse large B-cell lymphoma that I will talk about. So maybe starting back at the time when I was an undergraduate medical student at Stanford is really what's had the greatest impact on my career. And this one individual in particular, Ken Melman, who some of you who have been here for a long time know. Ken was a former chair of the Department of Medicine, and so great to be back here giving medicine grand rounds in his old stomping grounds. Ken was actually the very first person I met as a freshman on the front steps of my dorm freshman year. And I told Ken that I was interested in Romance philology, so the study of languages across the Romance languages, French, Italian, and Spanish. And he said, "You're somebody who's never going into medicine." But from that time to the present, we got to know each other very well. He became a mentor to me. And Ken had a really a special knack for putting people in situations where they never had any business being. And I was one of those people that was fortunate in that my very first presentation was actually in a program that Fernando Mendoza set up for minority medical students here on campus. My second presentation was this presentation that Ken set up to the Institute of Medicine, so the National Academy of Medicine, when I was a medical student. I didn't know that was a big deal until I was looking at a Princeton professor sitting next to me who was shaking in her boots right before her presentation. I said, "What are you nervous about?" And she explained to me who I was presenting to. But that was around this work, around the development of new therapies and the role that clinical investigators play in the development of therapies in medicine. And what we essentially found is that inside of the company of Burroughs Wellcome, George Hitchings and Gertrude Elion, who eventually won the Nobel Prize for their work, first discovered that purine analogs could be used as antimetabolites for any particular drug that was focused on DNA synthesis and the turnover of DNA. And so in 1942, they said that those could be used as antibacterials, antivirals, for therapy for immunosuppression, or as anti-leukemics. And you can see here that eventually in the mid-1950s, the anti-leukemic 6-MP, which we still use today in pediatric leukemias, was developed. But it wasn't until the 1980s that drugs were developed for HIV, and AZT was developed out of that same enabling observation in 1942. And essentially what we found, it was the drive of clinicians who asked for drugs for particular therapies for diseases that ultimately led to those discoveries, whether they were short-term discoveries or late discoveries. And that's really what drove me to want to become one of those clinicians who was able to take enabling observations and translate those into medicine. And so I'll really spend the vast majority of the rest of my time talking about the lymphomas, which has been my passion that also grew out of work that I did here with Ken connecting to immunology, and then with the group in the Fred Hutch and Ollie Press. And this work that we published back in 2016, which is now overdue for an update, which was the first time that we provided an annual incidence of lymphoid cancers in the United States using the same method that the American Cancer Society does to produce the cancer facts and figures. I also euphemistically call this a publication that was designed to take away citations from the most cited person in the world. So the second to last author next to me is Ahmadin Jamal, who produces the annual Cancer Facts and Figures and has done that for the last 20-some years. That's the most cited publication every year, and he consequently has been the most cited person in the world. But one of the things that they never did was to provide incidence data about lymphomas by lymphoma subtype. And what you can see here, diffuse large B-cell lymphoma listed as DLBCL down in there in the bottom portion of the pie chart, constitutes about 27,000 individuals who are diagnosed with that cancer each year, or that subtype of lymphoma. Next to it in the gray box is PCN, or plasma cell neoplasm. That's all of multiple myeloma. So you can see that this one subtype of lymphoma actually constitutes more individuals than all of multiple myeloma put together. The other thing that we know about diffuse large B-cell lymphoma, this biggest portion of the pie chart, is that if you look at the survival associated with that disease, as Ash alluded to, that really has been based for the last 20-some years on this survival curve that I'm showing you, where you can see here on the probability of survival on the y-axis and the years of survival, that this pivotal trial that was produced by the French group in Bertrand Coffier back in 2002 led to what had been the standard of care. So the older standard of care, actually, that was developed by investigators out of MD Anderson in the 1970s, was the regimen of CHOP chemotherapy, which is really the combination of 3 chemotherapy drugs with prednisone, which is the P. And the addition of rituximab, a drug that was developed out of labs at Stanford, was added to that chemotherapy, shown in arm B with the red dotted line, and that improved the outcomes for patients, as you can see dramatically in these survival curves, and became the standard of care back in 2002. But what the other thing that you can see from that is there's still a very deep drop-off in the survival for patients in those first 2 years. And there are multiple ways of being able to address that. One would be to intensify therapy over the standard R-CHOP that's given every 21 days, to be able to have better ways to predict and evaluate the quality of response for patients. And a third would be to take into consideration the biological diversity of diffuse large B-cell lymphoma. And I'll talk through the rest of the talk about each of those particular areas. When you look at the development since 2002, what you can see, as I showed you, is that R-CHOP was developed in 2002 based on that publication that I described. But over the series of really 2 decades, there have been multiple approaches to try and improve upon outcomes for patients. The first was to extend the therapy. So instead of giving it for 6 cycles, to give it for 8 cycles. That had no impact. The second was to be able to increase the dose density, giving it every 14 days instead of every 21 days. That also had no impact. As well did increasing the doses with what's called mega CHOP, which sounds like it should work better, but really didn't. Adding early autologous stem cell transplantation, or doing other things, including a multitude of regimens, adding new therapies to the R-CHOP regimen. And that really happened over a series of clinical trials that were all essentially negative trials, either substituting for the CD20 antibody rituximab with a different CD20 antibody, obinutuzumab, that has a trade name that starts with a G, and the GTOP regimen, giving infusional chemotherapy with additional drugs using the dose-adjusted EPOCH regimen, adding the drugs bortezomib or ibrutinib or lenalidomide. None of those, as you can see from the survival curves from each of those published studies, had any impact on the therapy. The only minor exception was the phase 2 clinical trial led by Greg Nowakowski that showed a benefit of lenalidomide R-CHOP over R-CHOP, but there was a confirmatory phase 3 trial that was a negative trial. And so that really also showed no benefit. And so one of the things that we did was to take the data from those negative clinical trials. And I think that's one of the areas where the foundation that I had both here at Stanford in medical informatics and the training in pharmaceutical outcomes and research and policy really helped to utilize old data in new ways. And we took the individualized patient level data from 13 of those randomized controlled trials, and then brought that back in to be able to understand how we could develop surrogate endpoints for new drugs to be approved more rapidly. One of the other things that we discovered through that work, and I mentioned this in my testimony to the FDA during the Oncology Drug Advisory Committee, is that if you use overall survival, which has been a standard endpoint for the FDA for new drug approval, it would take approximately 10 years to be able to reach that endpoint in new randomized controlled trials, which is really an unacceptably long period of time to wait to be able to approve new drugs to create new therapies for patients. And that came out of this work. The other thing that came out of this work was the development of progression-free survival as a new surrogate endpoint that could be used for the approval of new drugs in diffuse large B-cell lymphoma. So we took pre-specified statistical criteria for establishing surrogacy, having an R-squared weighted least squares or an R-squared copula of greater than 0.8, and with neither of those less than 0.7, and having lower bounds of the confidence interval being greater than 0.6. And across these clinical trials, where each of these clinical trials is shown either by a triangle or a circle, and you can see the code for how those trials were coded, and the size of the clinical trial in terms of number of patients is indicated by the size of the trial. And you can see that there's a tight correlation between the log hazard ratio on progression-free survival with a log hazard ratio on overall survival, suggesting that progression-free survival could be used as a surrogate. And that met our pre-specified criteria at the trial level, and you can also see had strong surrogacy at the patient level shown there. And that ultimately became the surrogate endpoint that was used in each of these randomized controlled trials. The other place where this was used was in the development of novel therapies that have moved beyond that, and that's now become an established surrogate endpoint for the FDA. And so as we think about the next steps moving forward for utilizing therapies in diffuse large B-cell lymphoma, there really have been a number of approaches. One was to take antibody drug conjugates, and I'll talk a little bit about that. I mentioned the monoclonal antibody for CD20 that has been used in those trials. Others, things that are moving forward in the future are the use of bispecific antibodies targeting both the lymphoma cells and targeting immune cells like T cells to bring those in to be able to attack the lymphoma, and novel combination therapies. And I mentioned some of those novel agents that have been attempted. So the drug that I'll spend a little bit of time talking about is polatuzumab vedotin. This is an anti-CD79B directed antibody drug conjugate, where you can see the CD79B that sits on the surface of the cell shown there, where polatuzumab binds to that cell surface marker. And then one of the things that we found with the use of naked antibodies with CD79B in lymphomas is they really were not effective at all. And the reason why they were not effective is that when it binds to CD79B, that gets internalized into the cell and is not exposed externally to be able to bring in immune cells to be able to attack the lymphoma. But polatuzumab vedotin is attached to MMAE, so a cell poison, a microtubule inhibitor. And so when that gets internalized, it also kills the lymphoma cells. And so really a perfect application of an antibody drug conjugate. That was first tested in this trial that I was part of when we were at Emory that led to the first approval of polatuzumab vedotin in the relapse setting for diffuse large B-cell lymphoma, where you can see in terms of the overall survival benefit in the relapse setting that polatuzumab plus a combination of chemotherapy, bendamustine, rituximab had overall survival benefit compared to bendamustine, rituximab alone. So consequently, when a drug is approved in the relapse setting, the next steps to think about that is how to move that into frontline therapy. And that was really moved in this clinical trial, the Polarix clinical trial, where we took patients who were newly diagnosed with diffuse large B-cell lymphoma and fell into a higher risk category, those who had an International Prognostic Index or IPI score of 2 through 5, and then enrolled those patients ages 18 to 80 into this clinical trial, where they were randomized 1-to-1 in a blinded fashion to either the standard R-CHOP regimen or to polatuzumab plus RCHP, where the vincristine is dropped and a placebo is given, and a placebo for polatuzumab was given in the other arm of the trial. The other thing that is part of this trial is really the legacy from the French group that was part of this, and that's that the French group still typically gives 8 cycles of therapy, regardless of the fact that we found that 6 and 8 were equivalent, and so 2 additional doses of rituximab were given to keep the French happy. The other component, so I was the US lead for this clinical trial and was the co-senior author in the New England Journal of Medicine paper that demonstrated the approval and ultimately led to the approval of this agent. And the primary finding from that study is shown here, and that was a benefit in progression-free survival, the endpoint that I told you that we established as a surrogate endpoint for diffuse large B-cell lymphoma in the front line, where you can see on the green curve that Pola-R-CHP improved progression-free survival with a hazard ratio of 0.73. And so that essentially meant a 27% reduction in the risk of death or progression or relapse for patients who received this regimen and fell into those higher risk categories. with a 24-month progression-free survival of 76% for that group versus 70% for the R-CHOP group. I think the other thing to note about this is that if you think back to those survival curves that I showed you for R-CHOP in 2002, there was about 50% survival with R-CHOP in 2002, and now about 70% survival with R-CHOP in 2023. And so you can see that over time, the standard of care is also improved for a number of reasons. One, because of its selection criteria into the clinical trial, and others because of the supportive care that we give to patients over time has improved. But you can see that despite that, Pola-R-CHP still provided improved survival for patients. But I think one of the key things to try and understand from that point forward is which patients are benefiting most from this therapy and what are the best ways to administer this in clinical practice. And that was a point that I made when I presented this at ODAC, that this is truly a meaningful benefit for patients where progression-free survival by itself is meaningful because those patients who are alive and progression-free at 2 years are generally considered those patients that are on their pathway towards cure of their lymphoma and will never or unlikely to ever have relapse of their disease. And so as we think about how to try and identify who are those patients that are most likely to benefit, the other thing that's been going on throughout my career is the evolution of the molecular classification of lymphomas, where back when I was starting and was a medical student at Stanford, we were thinking about Hodgkin lymphoma versus non-Hodgkin lymphoma as being the major classification schema. Over time with immunohistochemistry or IHC, we've been able to classify lymphomas into those that arise from T-cell lineage versus those that arise from B-cell lineage, which is all of those that I've been talking about. And then on top of that, gene expression profiling or GEP has been a way to develop those subtypes, and I'll talk about that in a little bit. And then beyond that, there have been other ways, including next generation sequencing to define lymphoma genetic subtypes or genomic subtypes. And really the first and most critical paper is from the guy in the front row, and that's Ash's paper from Nature in 2000 that really established the classification of diffuse large B-cell lymphoma as being important in terms of the way that we think about molecular subtypes, defining that into a germinal center or a GCB like diffuse large B-cell lymphoma subtype and an activated B-cell like the subtype. That's gone on from both work that Ash has done here and others, David Scott from the group in British Columbia, showing utilizing assays that we can define the GCB diffuse large B-cell lymphoma or the germinal center shown in the yellow curves that have a more favorable survival versus those activated B-cell like diffuse large B-cell lymphomas that have a worse outcome. And we also have been others who have defined how this genomic classification links to the mutations that are associated with the tumor. The other work that has come from that was a commentary that Ash, David Kurtz, and the group at Stanford made on our New England Journal of Medicine paper, looking at the efficacy of polatuzumab in diffuse large B-cell lymphoma subtypes by cell of origin. And you can see that those who fell into the GCB subgroup shown in the gold here had worse potential benefits from polatuzumab in a number of clinical trials compared to the activated B-cell-like subtype shown in the blue. And so that was something that we sought to explore in secondary analyses of our data. And this was presented just last year at the American Society of Hematology meeting in December, and has a publication that's forthcoming where we've gone back and used gene expression profiling to reanalyze the data from the Pola-R-CHP trial. And you can see here in terms of the survival curves that there's a marked benefit for those groups who have the ABC subtype shown in the blue versus the group that received R-CHOP shown in the green. And that was not really true for the GCB subtype and actually had an opposite effect in the unclassified subtype, although in relatively small numbers of patients in those portions of the clinical trial. But I think one of the things that goes beyond that is that it's not simply cell of origin alone that defines where the benefits might be for future therapies. And there have been other signatures that have been layered on top of that. The second of those is this signature that's now called the dark zone signature. This used to be called the double hit signature. The double hit signature and dark zone signature are exactly the same signature, so the new name for old Coke. But essentially with this dark zone signature, that defines a subgroup shown here in the red that even when you look at the germinal center, shown here in the yellow, and the activated B cell-like subtype, that dark zone positive patients also have worse outcomes. When you look at where these patients come from by cell of origin, the majority of those dark zone signature patients come from the GCB subtype. So there's a group within GCB that also has worse outcomes. And we went back to look at that as well in the Polarix clinical trial. And using gene expression profiling to define the dark zone signature patients, you can also see that among those dark zone signature patients, that the Pola-R-CHP arm fared better than patients who received R-CHOP in that particular arm as well. Whereas those patients who had germinal center or GCB diffuse large B-cell lymphoma and were dark zone signature negative really had no difference in outcomes between those two arms, and maybe a slight benefit for R-CHOP there. And what we also saw from that, looking at this Sankey plot as shown here, is if you look at the germinal center diffuse large B-cell lymphoma, the majority of those dark zone signature positive patients came from that. It's not really possible by the way that the gene expression work is defined for them to become from GCB, but there were a few that came from unclassified. And the other thing to note is that if you look at the totality of patients with germinal center B-cell lymphoma, that about 23% of them come from the dark zone signature subgroup. And so were we to make a decision that we only use particular therapies for all GCB, there would be that 23% that we may errantly give the wrong therapy to. And I think that's an important thing, that as we think about using genomic profiling to be able to classify patients and to be able to apply the most appropriate therapies in the future, that we need to take into consideration. Beyond that, if it wasn't complicated enough, there are multiple other signatures that have been applied to that. I'll just go through just a very few of them. The first is this one that was developed by the group at the NCI from Lou Stout's group that defined different subtypes of ABC diffuse large B-cell lymphoma and some subtypes of the GCB diffuse large B-cell lymphoma. Here now using mutations as a way to classify those lymphomas. Probably the most significant of those is the EZB MYC positive GCB diffuse large B-cell lymphomas that overlap significantly with dark zone lymphomas. The other thing to note here that's also important, though, is if you look at the prevalence of each of these lymphomas defined by the NCI classification, there are about 40% of lymphomas that would be unclassified. So we really need other methods beyond their approach to classify lymphomas. The other important thing for new discovery and development of therapies is the way that this links back to B-cell biology and B-cell subtypes, both in terms of the kinds of precursor conditions that may lead to diffuse large B-cell lymphoma, like chronic lymphocytic leukemia or marginal zone lymphomas, or follicular lymphoma, that are some of those other lymphomas that I showed you in the pie chart that may be precursors to development of diffuse large B-cell lymphoma. And those relate directly to the genomic subtypes that I described either by the method defined by the NIH or the NCI and a method defined by Margaret Shipp using cluster terminology, where she defines those as cluster 1 through cluster 5 that coincide roughly with the NCI classification. We also have utilized the Polarix data to try and explore that, and you can see that there are differences, in, at least for some of the subtypes, by those methods, but we really need many, many more patients to be able to describe that in much more detail. And you can there were relatively few numbers of patients by subtype where we had data to be able to do these classifications. And then the final way of classifying lymphomas are approaches to be able to classify it not just by the gene expression profiling of the tumor, but also the tumor microenvironment. So the immune cells that are within the tumor that helps to classify the data. This is work from the group at Boston Gene and Leandro Trichetti at Cornell. Ash and their group have done other ways of classifying the microenvironment. The one thing that I like to highlight from this paper that really was exciting was the group at Cornell actually did gene expression profiling on 75 patients with diffuse large B-cell lymphoma. The remainder of the 4,600 some patients were actually data that they garnered from the previously published literature to be able to reuse and to be able to develop this signature. But what they define is that if you look within the microenvironment of the tumor and define different subsets, a germinal center-like subset, a group that's called mesenchymal, a group that's called depleted, shown here in the red, that even after classifying for ABC and GCB, diffuse large B-cell lymphoma, that those microenvironment subsets also stratify patients into groups that are poor risk, and that there may be other ways that we need to target tumors to be able to improve outcomes for patients. And so what we've done at MD Anderson is to be able to integrate that into a testing methodology that you can now use for patients at the time that they're diagnosed or when they relapse with their diffuse large B-cell lymphoma. This is a protocol that I put together in late 2022. One of the great advantages of being at MD Anderson is the patient volume that we see to be able to run these kind of protocols. I opened it in early 2023, and we've now enrolled close to 100 patients on this study. Using lymphoma classification within diffuse large B-cell lymphoma, where the main question asked in this study is, can we get a complete genomic classification of patients back in less than 7 days from submission, with the goal being to try and target greater than 65% of those patients having data back within 7 days. Our feeling was that if you couldn't get patients' data back within 7 days, then you probably would not have data back in time for being able to make decisions about their care. And these are preliminary data. This will get presented at the AACR meeting, but this just shows that in about the first 30-some patients that we were able to do that both in the newly diagnosed and relapse setting, and to give back both lymphoma subtype by their NCI classification, to give back data on dark zone signature, and to be able to give back data on their microenvironment. The next steps really from there are to be able to use that in decision-making in real time for patients to decide what their therapy should be. The other parallel approach that we've had is work that's been led by my colleague Jason Weston at MD Anderson, where we've really tried to decide ways to turn lymphoma therapy on its head and to find very new and different strategies for treating patients. And this is a regimen that was developed called the Smart Start regimen, where patients do not get chemotherapy as their initial treatment for diffuse large B-cell lymphoma. So when Jason first presented this concept to me at one of the symposium or workshops for training junior faculty that Ash mentioned, the Lymphoma Research Foundation Clinical Research Mentorship Program, I told Jason he was crazy, that we should never do this to patients, that if we were to do this, patients would die because you have to give patients chemotherapy. Turns out I was wrong. And what happened is in this trial that now is published in the JCO in 2022, is that giving this regimen of rituximab, lenalidomide, and ibrutinib to patients for 2 cycles of therapy in this first regimen, what you can see that only one of those first 58 patients enrolled progressed. And there were even about 21 of those patients who went into complete remission without chemotherapy given at all for the first 2 cycles of therapy. And you can see here the 2-year progression-free survival was 91% for those patients after they were added on to complete 6 cycles of therapy. What we've gone on to do after that is a regimen that is now called Smart Stop. This was just presented at the ASH meeting, now combining rituximab, lenalidomide, acalabrutinib, and tafasitamab, so a combination therapy upfront without chemotherapy, where patients get 4 cycles of therapy, and those patients who get a complete remission go on to only get 2 cycles of therapy instead of the standard 6 cycles of therapy. What was presented at the ASH meeting this year is, if you look after the first 30 patients that we enrolled on this trial in just a little bit more than a year, that the overall response rate was 100%, and 64% of those patients had a complete response without chemotherapy. And then after 2 cycles of therapy, 94% of patients were in complete remission. And so now what we're going on to in the second cohort of this study is to allow patients who go into complete remission to actually complete therapy without getting chemotherapy at all. And I think this really speaks to the ways that we can advance therapy for patients, that there may be a subset of patients within that molecular classification that may not need chemotherapy as an approach to their treatment, which really would be revolutionary for patients. The other ways that we are thinking about how to move that forward is how to bring that back and connect it to the subtypes. And so the group at the NCI and others have thought about ways that each of those subtypes may have particular susceptibilities to particular drug targets. And now we're working towards creating Smart Stop therapies for each of the different subtypes that directly target the particular susceptibilities of those lymphoma subgroups. The next technology that I said that I will mention is the use of cell-free DNA and how that steps into this work. I showed you through the SmartStop trial how cell-free DNA was being collected during that. And cell-free DNA really creates an unprecedented opportunity for us now to be able to profile patients without needing a biopsy of their tumor. What this cartoon shows is that with the tumor being adjacent to blood cells, that it actually sheds DNA into the bloodstream, where you can collect and utilize that cell-free DNA to be able to understand the genomics of the tumor, as well as things like the gene expression profile. And for diffuse large B-cell lymphoma in particular, the circulating tumor DNA is the majority of the cell-free DNA that's in the bloodstream. I think this is a picture that really shows what all of us have typically hoped to achieve for patients when they complete therapy, and that's to have a negative PET at the end of treatment. The challenge we face with that, though, is even though we see patients at the end of 6 cycles of polar chip or 6 cycles of R-CHOP, that even when they have a negative PET scan, we don't tell those patients that they're cured. And that's because even with a negative PET scan, patients still can relapse. And so one of the things that we've looked at as well in the POLARIX trial is the role that circulating tumor DNA can play in this. And I'll just show you one slide to illustrate that point. So these are all patients who had a negative PET scan at the end of treatment. And you can see that those patients who had circulating tumor DNA that was negative, that's shown here in the blue curve, had markedly different progression-free survival compared to those patients who were circulating tumor DNA positive. That creates an opportunity for us now to identify patients who have worse outcomes at the end of treatment, and potentially to intervene with other kinds of treatment strategies at the time they complete therapy and even before they have a clinical relapse. I think the last thing that I'll turn to is actually the work of Jordan Goldstein, who's here in the audience. Jordan was a medical student that worked with me when he was at Emory and I was at Emory, and now has looked at ways that we might be able to use circulating tumor DNA to improve upon something that I described at the beginning, and that's the role of progression-free survival as an endpoint for trials in diffuse large B-cell lymphoma. You can see that even with progression-free survival, that there still are limits to the ways that we are able to improve upon outcomes and the amount of time. It took over 20 years to develop trials. And Jordan, with Ash's group, has now defined that using circulating tumor DNA, we can use techniques like ctDNA positivity added to PFS to define a modified PFS, where we can read out endpoints from trials about 12 months sooner than what you would with PFS for the kinds of trials that I described, like the POLARIX trial. And so that really creates an opportunity to be able to improve outcomes. You can see it's been more than 20 years from the trial that I showed you at the outset that happened right as the time I was finishing fellowship to the trial that just completed when I moved on to late stages of my career with POLAR-CHIP. And we really need to improve upon the strategies for developing trials with approaches like the one that Jordan has defined. So in terms of the major take-home points for this portion of the talk and future directions, what we've defined is that POLAR-CHIP really provides a novel therapy for patients with an improvement in progression-free survival, and now has become a new first-line standard that is available for patients to improve their outcomes. We've also started to define what the molecularly targeted therapy can be for diffuse large B-cell lymphoma, and a series of strategies that we can now use molecular targeting with testing at the point of care for patients so that we can define subtype-directed therapy. And cell-free DNA really holds the future for being able to predict outcomes, both in terms of strategies to tailor therapy, but also in terms of strategies where we can improve trial design and improve the ways that we are the approved therapies even faster for patients and innovate much faster. With that, I'm going to shift gears a bit in my talk and finish out to talk about something that has really been one of the lifeblood of my career, and that's the work in the lymphoma epidemiology of outcomes cohort study that I've collaborated on with Jim Serhan really since about 2006 when we first envisioned the opportunity for this trial. One of the nice things about this U01 cohort study that I've led with Jim is that when I moved from Emory to MD Anderson, all I had to do was switch the icons on this slide. But this has really been a great collaboration among 8 academic medical centers to be able to recruit now more than 8,000 patients onto an observational clinical trial clinical study where we've recruited patients. We build a tumor bank with tissue microarrays, collection of tumor DNA and RNA, and a central biorepository of peripheral blood, serum plasma, and DNA, and collect clinical, epidemiological, pathology, and treatment data, as well as prospectively follow patients for collecting patient-reported outcomes of their important items of interest. The other thing that's been very useful about this was the opportunity to mentor junior investigators through this effort, and the opportunity to be able to go back and forth between our work and the potential work in clinical trials. One of the great privileges has been to be able to work with investigators across the clinical trial leadership. Jonathan Friedberg, who's at University of Rochester and the head of the SWOG lymphoma chair, John Leonard at Cornell, who's the Alliance Lymphoma Chair, and Brad Call at WashU, who's the ECOG Lymphoma Chair, where we go back and forth between our observational cohort and discussions about how that can be used to move clinical trials forward. And one of the things that I'm most proud of from this work is that if you look across the LEO study, that our LEO demographics of our study really look like the demographics of lymphomas in the United States, with very similar distribution of the subtypes of lymphomas and very similar distribution in terms of race and ethnicity, where you can see that we have similar numbers of Hispanic patients enrolled in our study as what exists in the SEER data across the United States from 2015 to 2019. Similar numbers of African-American patients in this, and the group in the population that we miss in particular here are Asian Pacific Islanders, partly owing to the fact that the majority of our populations are to the east of the Mississippi, and we have a smattering of patients that we collect in the West Coast. But we do hit essentially all 50 states, and we hit both the rural population and urban populations, where we know patients who come from rural regions with lymphoma actually have worse outcomes. And so we've tried to study that as well. And this is the first 7,700 patients that we enrolled in this study that just got published in the American Journal of Hematology to describe our initial outcomes. We now have approval from our NCI funding to continue enrollment through 2026. With a plan to enroll about another 7,000 patients over that same time period. The other thing that we've seen that's been a challenge with diffuse large B-cell lymphomas are the increasingly restrictive criteria. Each of those trials that I showed you are represented by a dot on this trial, on this chart, and what you can see that over the ensuing years, there have been more and more eligibility criteria for trials, which is making it more and more restrictive to enroll patients. And we've now utilized data from LEO and clinical trials to be able to understand who gets left behind in clinical trials. And this is work from Dr. Khurana from Mayo Clinic, who first described this with the Mayo Clinic population to show that about 24% of patients, or up to 24% of patients, can get excluded from clinical trials based only on laboratory criteria. And when you look at those data sets, you can see that those patients who are ineligible by clinical trial are actually the patients who have the worst outcomes. And those are exactly the patients who we want to be including on clinical trials. You can also see, you might think that patients who are dying because they're ineligible are ineligible and dying because of other diseases beyond lymphoma. But if you look at the major causes of death that are associated with those patients who are ineligible, those are patients that are dying because of their lymphoma, as shown in red. And so we really need to be targeting therapies for those patients and increasing and improving our eligibility criteria. One of the things that we've used LEO to do is to try and understand the patient population in diffuse large B-cell lymphoma and how those criteria affect enrollment among different patient populations. And you can see in our LEO population of diffuse large B-cell lymphoma that really mirrors what you see in the population of patients in the United States. And what was found and presented by Dr. Khurana in ASH in 2022 at the annual meeting, and now is being moved forward for publication, is that if you look at the eligibility criteria for those existing trials, they actually are preferentially excluding the kinds of patients that we would like to include in clinical trials, both in terms of those that have worse outcomes and those that improve the diversity of trial enrollment. And so within the LEO group, leveraging the population of investigators, we have actually created a strategy with another one of my medical students, Andrew Harkins, who did this work, who's now a fellow at Mayo. So you can guess which of my medical students made the better choice. sorry, a medical student, was a medical student, is now a fellow at MD Anderson, that he leveraged the data across the LEO study to be able to understand how diffuse large B cells criteria could be simplified. And then we took what were 31 eligibility criteria and now have simplified those down to 13 eligibility criteria, so that now more modern clinical trials, and those are now being incorporated into modern clinical trials for diffuse large B-cell lymphoma to improve our enrollment characteristics and to allow enrollment of those patients that have the worst outcomes and to increase the enrollment of underrepresented minority patients in trials. The other thing that has been helpful here is I got a grant from the Leukemia and Lymphoma Society to be able to expand trial access to community-based centers. And this is something that we call the Clinical Trial Network of South Texas, where we've expanded trials to our county hospital, LBJ Hospital, which goes back and forth with Cook County Hospital as being the largest county hospital in the United States. That has a population that is about an 80% minority population, where we're enrolling patients with lymphomas on trials there, as well as community-based practices across Texas, where we're enrolling patients as well. And so with that, I'll thank you all for your attention. Would like to thank my funders for this work, the group at the National Cancer Institute that's funded our work with Leo, the group in the CPRIT, or Cancer Prevention Research in Texas, the Leukemia and Lymphoma Society, the V Foundation, and Burroughs Wellcome. But really the biggest thank you that I have to give of all is a thank you to Stanford that really provided the foundation that I needed to be able to go on and do this work, both as a faculty member at Emory and then in leadership of the Lymphoma and Myeloma group, the leadership of the Division of Cancer Medicine, that now we see more than 500,000 patient encounters on an annual basis within our group. And that's created a tremendous opportunity to be able to do translational team science, both in the areas of lymphoma, that's been my own, but also across a number of areas where we now have 9 SPORE grants connected to the work that we do across multiple cancers. So with that, I'll stop and happy to take any questions. I think, yeah. Yes.
To the ABC population, that's that is that I assume that there might be some.
Yeah, that's a great question. So the question was, should we be preferentially giving therapy to a specific group, the ABC subgroup, based on the data that I showed and based on the safety profile. One of the slides that I left out of this presentation was the slide on the safety profile. And essentially the safety profile of the two regimens are identical or equivalent. The FDA even, that was a big portion of our presentation to the FDA. The FDA actually asked us not to present any of that because they also concluded the safety profile was essentially equivalent. The major toxicity of polatuzumab has really been in neuropathy. That's a cumulative neurotoxicity that occurs typically after 6 cycles. And so if you limit it to 6 cycles, it's no different than giving vincristine. The other differences in the safety profile is that there is more neutropenia for patients who get polatuzumab as part of their regimen. That can be mitigated by giving GCSF with the regimen, and there was no difference in infectious rates. So no real difference in the toxicity. The challenge with being able to implement what I showed is the way that we determine who's ABC or GCB. The most common way to do that in the United States is to use immunohistochemistry stains on the tumor block. The problem with the most common approach for doing that using the Hans algorithm is that it misclassifies approximately 20% of patients. And so if you were to do that and make decisions based on that, you would be treating about 20% of patients the wrong way based on that decision. And so, I've advocated that we not make decisions if you're only going to use immunohistochemistry, and you really need to use gene expression profiling or gene expression profiling equivalent tests. The only group that I know in the world that is currently using gene expression profiling is a group in British Columbia that has that built into their algorithm. They actually don't have polatuzumab approved in Canada, and so can't use it to make decisions. The approach that I showed you that we're now doing is something that we will be moving into clinical practice at MD Anderson to be able to do gene expression profiling in real time.
Thank you, Chris, for a very inspirational talk. We have a couple questions online out. One of them is from David Kurtz. Thank you for the excellent talk, Chris. The subtype-driven effects of polar R-CHP are striking, as the benefit seems to be limited to the activated subgroup and maybe the dark zone positive patients. How do you see us translating this into the clinic, particularly because gene expression tools aren't readily available in the clinic?
Yeah, so I think David hit exactly on the point we're making. I think there is a strong need to be able to push forward either gene expression-based assays or assays that very closely recapitulate what we know gene expression to yield. And as soon as we have those in the clinic, I think that will help clinicians at the bedside to be able to make those decisions. That could happen at the first cycle of therapy. That could potentially even happen at the second cycle. There are technologies in cell-free DNA that are moving in that direction and may make that available through blood testing to be able to recapitulate the gene expression profiling and the assays that I mentioned that are tumor-based assays that currently exist in a couple of areas.
Really nice talk. I was really intrigued by the Smart Start and Smart Stop data and was curious as to whether there's any data on the genetic subtypes of the patients who had a CR in the Smart Start. And if so, moving forward to Smart Stop, are you all considering targeting specific subgroups of patients with DLBCL?
Yeah, a really fantastic question. So in Smart Stop, and thanks, Melody, for that one. I think there are a few things. One, with the Smart Start data, we've gone back and to try and profile those patients. We really did not have perfect and adequate collection of samples to be able to do that well. The other thing that has been a problem with these regimens, which is, I guess, a good problem to have, is that the response rates were so high that defining those patients who are responders versus non-responders has not been adequate to be able to identify subtypes of patients who were non-responders across those classifications. One of the things that we're doing in that regard is using now cell-free DNA as an approach to define those who are responders versus non-responders, because that's now a more sensitive approach to identify those non-responsive groups, and then linking that to our molecular profiling data. Really, what I envision that we'll be moving forward with first is using gene expression profiling or other molecular classification assays with the current kinds of therapies that we have, like polar R-CHP, to make decisions within clinical practice, but also running clinical trials that are using multi-arm randomization for patients to either get one of those subtype-directed therapies with different versions of what we'll call Smart Start, our next generation of Smart Stop, for each particular subtype, where we'll randomize patients to that versus standard of care with an adaptive randomization by molecular subtype.
While we're waiting for questions, I have one. I was very intrigued by the strategy for simplifying eligibility criteria as a way to avoid excluding patients. Related to that same concept is the testing burden for selection of patients that lead to these baked-in biases that the group at Mayo Clinic has nicely highlighted. The diagnosis to treatment interval, where patients who get enrolled have been selected for those that do well. How do we decrease that bias in our trials? How do we guard against that?
Yeah, really fantastic question. That really underlies one of the things that I showed you earlier, and that's that the standard of care arm with R-CHOP is dramatically improved over time. Some of that it relates to the things that I mentioned about the improvement of the support for standard of care, but another part of that relates to the selection criteria that we're using for trials. So we are now selecting really the patients who you expect to do the best with R-CHOP into our clinical trials and trying to define trials to improve upon that. really what we need to do, and as we're proposing to do, is to be able to expand eligibility criteria so that we can allow enrollment of the patients who are in the greatest need. We're hoping, some of the brand new clinical trials are now utilizing that. So there are 3 new frontline trials that have taken our eligibility criteria and at least used those in helping to design their trials. We also need to expand enrollment to larger populations of patients and have ways to be able to identify those patients in a more rapid fashion to be able to enroll patients in those trials. I think all of those are complex questions, but one of the things that we would hope to see is that the standard of care arm actually performs worse than what it's doing now if we're actually attracting those patients. One of the other things that Leo has allowed us to do is to identify a cohort of patients who are eligible for trials and to see which patients actually go on trials versus not. And so I think I took that slide out, but one of the things that we propose to do is actually to enroll patients on Leo, check their eligibility criteria across our academic medical centers, and to see those who actually go on to a clinical trial and compare those who don't go on a clinical trial in terms of their outcomes to those who do.
Oh, no, sorry.
Oh.
I'll ask one more question. I guess in the context of the randomized studies over the last 2 decades that you mentioned, there some interesting observations have been made about ethnicity and demography and pretty dramatic biases of that in relation to the molecular groups, particularly in East Asians for the activated subgroup. How do we approach that going forward? Is it identifying the genetic determinants of risk or genomic or genetic ancestry? What's the best way to capture that risk?
Yeah, that's a fantastic question, and actually a whole other talk that I have to get. I have a few slides that touch on some of that, but I won't go through that in detail. But one of the things that we've also focused on is disparities in lymphoma outcomes over time. But to get specifically to your question, we've taken and redone some of the analyses of the genomic data and looked at ancestral informative markers to be able to look at the ways that ancestry is associated with particular genomic subtypes for patients. These actually have gone through a reanalysis. There were some challenges with some of the ready data, and we've actually now reanalyzed that using the Gamble data set. That was an improvement on that. But what you can see is if you look by ancestry, there were differences in outcomes for those who have greater than 90% African ancestry. We didn't have sufficient really numbers of patients of East Asian ancestry, but it's been shown in other settings that patients who come from East Asian ancestry have a greater preponderance of activated B-cell like diffuse large B-cell lymphoma. But patients with greater than 90% African ancestry had worse clinical markers like higher LDH, like more advanced stage and B symptoms, and have been able to find particular mutations, particularly a mutation in SETD2 and other truncating mutations that are associated with worse outcomes in that diffuse large B-cell lymphoma patient population of African ancestry. And now we're utilizing that in collaboration with Ari Melnick to be able to define selected therapy for those of African ancestry, where I've been involved in a phase 1 clinical trial of a new SETD2 inhibitor that may be synthetically lethal in patient populations that are greater than 90% African ancestry. And so I think that really creates a unique opportunity for being able to target that. The thing that we need is we need much larger data sets. And so we're now taking our data set of our first cohort of 2,150 patients with diffuse large B-cell lymphoma in Leo, where we have about 12% of those individuals who were of African or self-reported race of African American, and then doing genomic subtyping of those patients, and then being able to see this in a larger cohort to see can we validate that, and then to move that forward for approaches for therapies for particular populations.
Wonderful. Thank you. So I think we're at time. Thank you, Dr. Flowers, and thanks again, everyone.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.